All right. So I know you've heard a lot of amazing, really complicated things about the heart, genetics, and the lungs. But as an immunologist, I think we need to turn our attention to the spleen. I don't think the spleen gets enough love and attention, so I'm here to correct that. So, the issue in heterotaxy is there can be asplenia, polysplenia, so basically anywhere from absence of spleen function to impaired spleen function. And what that results in, unfortunately, is susceptibility to some overwhelming infections. So I think it's helpful just to give a little bit of background on the spleen. I'll be going into more depth tomorrow, but the spleen you can think of as, like for a car analogy, the oil filter of the body, basically. So the spleen is an organ commonly located in the left upper quadrant here underneath the rib cage, and it receives blood directly from the circulatory system, and what it does is it filters the blood continually. So roughly speaking, the spleen is divided up into two distinct sections, one called the red pulp and one called the white pulp. So the red pulp is basically these sinusoids where the blood is filtered through a series of macrophages, and these are really tight little sinusoids, and the way it works is blood cells, particularly red blood cells, as they age, there can be hemoglobin proteins that precipitate in the blood cells, and they form what's called little pits. Also, there can be remnants that accumulate in red blood cells during development called Howell-Jolly bodies, which are nuclear remnants. So in a normal functioning spleen, what happens is the red blood cells squeeze through these little channels in the red pulp, and those pits and the Howell-Jolly bodies aren't very deformable. So what happens is they basically get shaved out of the red blood cell, okay? And then the membrane kind of reanneals, and then the blood cell goes on its way out in the circulation. Older blood cells will present a molecule on their surface called phosphatidylserine, and that signals to the macrophages that these blood cells need to be removed from the circulation, and all of those products get recycled. The white pulp, on the other hand, is a site where a lot of complex immunologic reactions happen. So the spleen not only filters old blood cells and cleans them up, it also is a place where pathogens like bacteria and viruses get filtered through. And as they go through the macrophages in the red pulp, they may recognize and engulf some of those bacteria. As the blood and all of those pathogens are presented to the white pulp, there are a variety of cells in the white pulp that then recognize those foreign bacteria and viruses and elicit immune responses that go on to protect the body and help ultimately clear infections of all sorts. There are a specialized set of lymphocytes called B cells, which produce antibodies. And a subset are quite unique to the spleen. They're called IgM memory B cells. They sit in an area called the marginal zone, and you can think of them as one of the first lines of defense against certain bacteria, in particular strep pneumococcus, Neisseria meningitidis, and Haemophilus influenza type B. These are difficult bacteria because they have these slippery capsules which are comprised of polysaccharides, and they make it difficult for the macrophages to engulf them. and they're resistant to being coated with special proteins of the immune system called complement. So what these memory B cells in the marginal zone, which are kind of particular to the spleen, they secrete these IgM antibodies right away, which can bind to the polysaccharide coatings on these bacteria, and that gives the immune system the ability to help clear those particular subsets of infections. So in a situation where we don't have a spleen, we don't have that filter, and we don't have that immediate immune response from the IgM B cells, so that gives bacteria like Streptococcus pneumonia and Neisseria meningitidis, encapsulated organisms get a better chance to grow and overwhelm the body. So that's why absence of a spleen or impaired splenic function is so dangerous. So what do we do? Well, as immunologists, what we counsel our patients on is that if they develop a fever, and we're concerned about fevers that are greater than 101.3 degrees Fahrenheit. If they develop a fever, they need to be evaluated by a physician, primarily in the emergency room, so that you can get blood cultures and get a dose of antibiotics while the cultures are pending, so that they can be protected against these infections. Although the overwhelming infections are fairly rare, when they do occur, there's a 70% mortality rate. So it's really important to prevent this type of a situation from occurring. So the way we do it is we tell patients basically for fevers greater than 101 degrees Fahrenheit, we need you to go to your nearest emergency room, check in, get looked over. They can do viral respiratory panels, and they can do the blood cultures. They can give a dose of antibiotics while the cultures are pending, okay? So why this temperature of 101.3 degrees? Well, the studies have shown that the incidence of overwhelming infection is much lower below 101 degrees Fahrenheit. So we use that as our cutoff for patients to seek attention. But for kids who have just kind of low-grade viral symptoms, cough, runny nose, fevers less than 101, they can be managed at home. And if they don't progress, then that is a wonderful situation. So that is our fever protocol in asplenia and hyposplenia, and that's kind of the logic behind why we do what we do. So I'll stop at this point. Does anybody have any questions or concerns regarding any of this information? Yeah.
So this was actually asked on one of our support groups. When we're talking about a fever cutoff of 100.3, that's before we give medication, right?
So 101 degrees Fahrenheit. 101 degrees Fahrenheit is our cutoff. Anything above that, we would really prefer that they get evaluated by a physician.
But the question is, the temperature needs to be before they give them ibuprofen or Tylenol, correct?
That's correct.
Right? Not wait until you've given it that and wait for it to go down.
Right.
And then have a sustained fever, but just if you hit that threshold before you take the medication.
That is correct, yes, yes. And that's a great point. Any other questions?
Some of our families have been given 100.4 as a fever threshold. Has that changed recently? Like you just mentioned that study. Can you just speak to kind of where that shift has come and maybe what the most recent guidance for the 101 is? Yeah,
so that's what's based in the asplenia literature, the 101.3 degree cutoff, and kind of based on the incidence of bacteremia above and below that cutoff. I certainly don't have any arguments against setting that threshold a bit lower. It's just that basically what we're trying to do is set a threshold whereby you're not going to the emergency room all the time, okay? So if we stick to that 101 degree Fahrenheit, I think that will give kids, you know, the opportunity to get a routine cold, low-grade fever without going to the emergency room too often. So there is kind of advantages and disadvantages to the different cutoffs. Yes.
I feel like I ask all the questions, sorry. So in our community support group, this discussions over this fever protocol are probably the most common. So here's what, the longevity of the fever. Is that different in complex kids like ours than from normal kids? Because, for example, my daughter's physician says if she has a fever that's exceeding 5 days, doesn't matter if there's no other symptoms, if that fever is not going away after 5 days, come in. Should that threshold be the same for a child that's complex CHD, and asplenia?
Mm-hmm. Yeah, and I think that's an excellent question. So what I would say is for fevers that are going on, smoldering longer than expected, it is worthwhile getting evaluated by a physician. They could check a respiratory viral panel to see if there's evidence of viruses, and it's just good for those kids to have eyes laid upon them just to make sure that there aren't any other localizing signs that might need to be addressed. Does that help?
But is the length, the length?
Yes, I would say yes. Even in the setting of ongoing low-grade fevers, if it's persisting beyond your usual cold duration, I would get that child evaluated. All right. So how do we prevent infections? Well, there's really, from an immunology perspective, there's two cornerstones. One is antibiotic prophylaxis. So this really applies to that subset of patients with heterotaxy, with asplenia or hyposplenia, meaning reduced splenic function. So there are plenty of patients who we evaluate. We evaluate their splenic function, and just to kind of backtrack, the way we do that, at least at our institution, is by sending off an RBC pit count. And that assay is done in a specialized lab at Cincinnati Children's Hospital. So the cutoff is 1.3% pitted cells in the circulation. If that number is greater than that, then we interpret them as being hyposplenic. And typically values greater than 14 to 15% are what we will find in patients with asplenia, okay? So that's kind of the cutoff. The other assay that we do is we quantitate those special B cells that I talked about, the IgM positive memory B cells. If those are also low, that's also another marker that supports hyposplenism, okay? So for those patients, we typically recommend antibiotic prophylaxis, and our most common choice of antibiotics would be amoxicillin because it's relatively easily available, and we usually give a dose of 10 milligrams per kilogram twice a day, okay? You can also use penicillin VK as an alternative for patients who are amoxicillin allergic. There are macrolide class antibiotics that can be used, such as erythromycin, azithromycin. You can oftentimes use first-generation cephalosporins like cephalexin as an alternative. I will say, putting my allergist hat on, that amoxicillin allergy generally gets overcalled because there are so many kids who get rashes when they get sick, and they happen to be taking amoxicillin at the same time, and they get labeled as being amoxicillin allergic. So as an allergist, I will say that a presentation for allergy that is very low risk is for a child who has an infection, they're getting their first course of amoxicillin, and like a day or two into the course, they get this non-specific red, non-itchy rash. That is not likely to be an amoxicillin allergy. Typically, amoxicillin allergies develop after a prolonged period of exposure, after 7 or 10 days, and that's usually associated with hives, itchiness, swelling, those types of symptoms. But if you have a child who's been labeled amoxicillin allergic, I'll put in a plug and say, it's good to get them evaluated by an allergist to see if you can clear them of that allergy, because it just opens up a lot easier care by removing that allergy label. Okay? So that is antibiotic prophylaxis choices. And so how long do we recommend? Well, there's no universal recommendation for the duration of antibiotic prophylaxis. Many will stop around, say, 5 years of age. In Britain, they usually go a little bit longer, towards adolescence. The one reason I don't like stopping at 5 years of age is because that's an age where kids are going to kindergarten and school, and they're starting to get exposure to a lot more infections, hence more fevers. So I kind of favor, at least in that stage of life, continuing on. But it's a discussion that you can have with your immunologist, and if your child is doing well, they've been evaluated, they've got normal immunoglobulin levels, they've got protective antibody titers to strep pneumococcus, to meningitis, to Hib, it's not unreasonable to stop antibiotic prophylaxis at that time. You just need to have a discussion about, again, fever protocols. The risk of overwhelming sepsis is a lifelong one, so the same approach needs to be taken with fevers, whether you're on antibiotic prophylaxis or not. So for fevers greater than 101, they still need to be evaluated by a physician and treated presumptively while that culture is in process, okay? Any questions about antibiotic prophylaxis or duration of therapy?
I'll come and ask just another question that's commonly come up in our community is, if your child does get a different infection per se that's they're being prescribed a different antibiotic for, let's say like Bactrim for a UTI, do they continue taking their prophylaxis at baseline? Is that something that changes or suspends whether or not they take their prophylaxis if they're requiring antibiotic for something else?
Yeah, typically we will have them just take the therapy that they've been prescribed, and they can stop the amoxicillin at that time, and once they have completed their therapy, go back to the antibiotic prophylaxis.
You just reminded me of another question that had come up, is when prophylaxis is being asked for say, like dental work or like something that one really particularly comes out, are they supposed to take the exact same prophylaxis that they're taking, or does that become different when they're having that type of procedure or surgery?
Yeah, great. So, so typically for procedures, we do recommend making changes. So typically we will recommend a higher dose of amoxicillin, typically 50 milligrams per kilogram an hour before the procedure. But if it's a different body site that may have different flora, we may go to something different, perhaps augmentin for broader coverage, or something like ceftriaxone. So it's good to keep procedures in mind, as well as what particular site. And you can talk to your immunologist or an infectious disease specialist about what the best treatment would be. But typically that low amoxicillin dose is not going to be sufficient during a procedure. Yes?
Another discussion in our family group is who is managing the prophylaxis, and does that change the decisions made as to dosage and how long to continue? For example, there are a lot of kids who are in areas where they still see heterotaxy as a cardiac issue, and it is a cardiologist that's managing the prophylaxis. Other areas, somebody has 10 million specialists, and they have, a complex care pediatrician helping to manage, and everything's coordinated, and they've got immunology on board. So, and then some people, it's their PCM just making those decisions. And so how do we advocate to make sure we're getting what's right for us, the heterotaxy kiddos, based on their splenic function?
Yeah. So that's a great question, and I don't think that immunologists per se, have the right away on antibiotic prophylaxis. I think there are a lot of physicians who are well versed in antibiotic prophylaxis. So I think as long as they're sticking to the guidelines, which is easily available nowadays, just so long as you've got a knowledgeable physician, it doesn't matter if they're a cardiologist, immunologist, or even a primary care physician, just so long as you've got somebody helping provide guidance. All right, so any other antibiotic questions? This is really helpful because we're we're covering all the bases, basically.
What would you say, because this is also something that's on our group about, some people are told by their physicians or specialists that they don't need it ever, use other things. And then some are like, yes, they need it 100%. What would you tell families how to advocate, or if they feel really strongly that they need to be on this and then their doctors are saying, no, they don't? If that makes sense, just to have that conversation.
So that is an important question, and I think there needs to be good dialogue between your child's physician and you. What we do know is that impaired or absent spleen function infers a lifelong risk of overwhelming infection, okay? Not everybody is going to need to be on lifelong antibiotic prophylaxis, but some might, okay? Because some kids are much more complex than others, and they may have developed significant infectious complications along the way, and that's probably somebody you don't want to take off antibiotic prophylaxis, okay? But if you've got a child who has good antibody levels, good antibody titers, has really been very healthy for many, many years, I think it's reasonable to discontinue antibiotic prophylaxis. You just have to keep in the back of your mind that the risk is still there with those higher grade fevers or in the setting of a prolonged fever, okay? And certainly, kids who would develop other symptoms of concern like shaking, chills, and things like that, those are kids that we want to get evaluated right away. Okay? So I think that covers a lot of the issues regarding antibiotic prophylaxis. And it's hugely important. It really has prevented a lot of infections in asplenic patients, probably by 50 to 80%. So it's a very significant improvement in quality of life for those patients. The other cornerstone to keeping our kids healthy with heterotaxy and splenic impairment is vaccination. So the good news is that vaccination, the pediatric vaccination schedule covers Haemophilus influenza B, strep pneumococcus, and and tetanus and other things. It doesn't include meningitis, but those pneumococcus and Hib are covered in the standard pediatric immunizations within the first year of life. And the literature has shown that in terms of overwhelming infections, pneumococcus is by far the most common organism, followed by H. flu, type B. So they're getting those immunizations in the first year of life and should be getting really good antibody protection from those immunizations. We can also add meningococcal vaccine in the form of Menveo, which is a meningococcal vaccine that's given to children under 2 years of age, and that's a 4-dose series that can be given along with the other standard pediatric immunizations. Okay, so you can have a discussion with your immunologist or care provider about whether you would like to add the meningococcal series at the same time, or after they've completed the standard, would they like to do it perhaps a little bit later. They're going to stay on the antibiotic prophylaxis, but kids over 2 years of age would then require a 2-dose of a different meningococcal vaccine, which is known as Menquadfi. We used to, there was another one that we used to recommend, Menactra, but I think that's been discontinued. So Menquadfi is the one that we're using at this point. And then up around 10 years of age, there's a meningococcal type B vaccine called Bexsero, which is recommended to give protection against meningitis type B. Okay, so those are the vaccine recommendations. And again, it's been hugely helpful in keeping kids healthy, out of the hospital. As an immunologist, I like to, after they've received their series, check their antibody titers and make sure that they've responded well. Because sometimes we pick up kids who either have low immunoglobulin levels, that's not always anticipated, or they don't respond as vigorously to the vaccines as we might expect. We need to identify those kids because they're in a bit of a higher risk category. But as an immunologist, what I've seen is there are subsets of kids who don't respond to the vaccines well, particularly earlier in life, but they do, as their immune system matures, they will subsequently respond, and it's good to be keeping an eye on that. But for the kids who are not responding for whatever reason, we need to keep them on the antibiotic prophylaxis. And as we work them up, we find that there are unexpected deficiencies in the immune system, like they don't make adequate immunoglobulin levels, they don't respond to the vaccines at all. Those are kids that we might want to provide extra support in the form of immunoglobulin replacement. So it's good to have an immunologist kind of keeping an eye on these kids, just so we can make sure that they're getting the best protection that they can get. Any other questions?
I'm just full of them today for our community, just because so much of this comes up. For kids who are some of our more complex kids who spend significant amount of time in the hospital, particularly in the first couple of years of life. Maybe they spend the first 6 to 9 months in the hospital, they have multiple cardiac surgeries, they're very frail, and they're walking out of the hospital, and routine immunizations have just kind of fallen by the wayside, or they come home and they're supposed to start, but then they go back in the hospital 2 weeks later. They're in and out, in and out, in and out, and now, you know what I mean, they blink and their kids haven't actually had the immunizations that they're supposed to have. Is there Any recommendations for immunization around critical illness or times that should be waited, or ways that our parents can keep this in mind so that our kids can work with their pediatricians and their care staff to catch up? And what is the most appropriate time to start catching up a child who's had critical illness and kind of multiple open heart or other types of surgeries?
Yeah, great question, because that type of a situation comes up a lot. So we generally try to avoid giving immunizations around particularly stressful times, like surgeries or critical illnesses. We would like kids to have recovered for about a month or so and be at their baseline before we start immunizations. And then we would try to get them caught up with a reasonable schedule. But you're right that critical illness is not a good time to do immunizations, and certainly around those times it's good for them to be on their antibiotic prophylaxis and be monitored a bit more closely.
Check marks for competition. On the note of our young ones, in heterotaxy, it is a trend that first year, that first 2 years is when they spend the majority of time in and out of the hospital, or mostly in the hospital. Can you speak to about Synagis and RSV? And I mean, this was a decade ago for my daughter, but she got Synagis, the series, for her first 2 years, and we were told at the time the only reason why it's only the first 2 years and not any further is because that's as far as insurance will cover. But I'm wondering what the standards are right now and what your recommendations are for our kids on that.
Yeah. So I think that still applies, but I don't think there's a one-size-fits-all. So I think it is good for the kids who are in the hospital a lot, on the cardiac service, to get immunology involved with them while they're inpatient. And then, if you can have a team, the cardiologists, the pulmonologists, and the immunologists, if they feel like a child is at risk for respiratory decompensation, advocating for an additional dose the next year, I would firmly support that. But it's, like I say, it's not a one-size-fits-all, right? And some of these kids go through some really difficult times. So I think RSV is a drop in the bucket, in terms of getting the immunization or the immunoglobulin compared to what they've been through. Anybody else? Well, I hope this was helpful. And I'll be around tomorrow also giving a talk on immunologic evaluation a bit more in depth tomorrow afternoon. But it's been a pleasure to chat with you guys today.